rounds. I'm very pleased today to be able to introduce our Locke visiting professor of cardiology, Eric Velazquez. I'll keep this very brief, but Eric is the Robert Berliner Chair of Medicine at Yale School of Medicine and is the chief of cardiovascular medicine there. He has had a storied career and actually needs very little introduction, but obviously was at Duke for a very long time and one of the major leaders at DCRI. It's rare that we get to introduce somebody who truly has changed the practice of cardiology, but you'll know that he has really landmark papers, including the leading the Pioneer HF trial, first author on that, the Stitch trial. I mean, just across the full range of things that we do as cardiologists, he's really changed the landscape for us. So it's a real pleasure to have him here today, and thanks for joining us, and we're looking forward to your talk.
Thanks, Greg, and really very kind introduction, and maybe not deserved, but I stand on the shoulders of giants that I was fortunate to be mentored by and to work with and collaborate with in my career. So first of all, I want to make sure this is working. I'm doing everything right. Okay, and I'm going to kind of take you on a little bit of a history ride and to address this topic better. Yes. Okay. And I chose this topic, which is something I've been working on really for most of my cardiology career, which is this focus on the population of patients who have heart failure with reduced ejection fraction, particularly in the setting of coronary disease. And so some of this is maybe known, but perhaps not fully explored. I'm glad to take any questions, and hopefully this will be helpful, put things in perspective of how I see this field and how it's transitioned. Let's see if it works. Okay, these are my disclosures. So my aims are quite limited. Really just to review a bit about the epidemiology of heart failure with coronary disease, try to contextualize current approaches and some of the evidence that I was fortunate to collaborate with others on developing on treatments with a focus on where the evidence stands currently with regards to revascularization as an adjunct to guideline-directed medical therapy, and kind of give you my perspective on where we need to go next. I'd like to start this talk with this quote and this information that is now 50 plus years old. And it just, I think for the fellows particularly, I think it could be valuable to just understand how far we've come. And so George Birch was, at the time when he wrote this and coined this term, ischemic cardiomyopathy, the editor-in-chief of the American Heart Journal and the president of the Association of University Cardiologists. The American Heart Journal at that time was kind of the jack of our society. And he described for the first time this concept of an ischemic cardiomyopathy as myocardial dysfunction that results from occlusive coronary disease that was the most common cause of cardiac muscle pathology in America at that time. And apparently, and this is, I guess, the point here, at that time, apparently once damage had occurred to the extent of the ischemic cardiomyopathy described, the disease was irreversible, even with absolute bed rest. So it gives you a perspective of what we did 50 plus years ago to treat patients with coronary disease and heart failure. And patients with the late stage of ischemic cardiomyopathy require astute and meticulous management in order to achieve the best possible results. That was defined as, and many such patients must lead the life of a cardiac invalid or semi-invalid to remain alive. It is unfortunate that this course is often necessary, but the physician and the patient have no other choice. And the sooner the way of life is thoroughly accepted by both, the better the results and the happier the patient will be. So just sit with that for a moment and say, that's just 50 years ago, and this, kind of will give you, I think, a sense of hopefully excitement and enthusiasm about the career and the organization that you're part of, because we've changed that. We've really made a major impact on that construct. But this is how patients were cared for at the time. So CAD, or coronary disease, is the most common cause of heart failure. And just a few kind of points to just bring that home. This is a Scottish registry looking at temporal trends and patterns in heart failure incidence in over 4 million individuals. And you know, without looking too closely at the marks on the slide, you know, you can tell here that ischemic heart disease really, in association with heart failure, represents about half of all patients with heart failure. And that's been pretty consistent, you know, and I think, as I'll share, is also, I think, the reality in both developed countries and lower middle income countries. It also relates to risk factors that are associated with those individuals at the lower spectrums of our socioeconomic status, and really doesn't avoid boundaries of race or ethnicity. This, I just have to give, you know, homage to Greg and the team here. So I pulled this up just to give you a sense of how heart failure is seen in terms of its global burden. And this is from the important work done here. We had an interesting conversation about why heart failure has to be its own class. It's not considered it's considered a condition in the global disease burden world. But you can see that large red box highlights that it is by far the largest contributor. Ischemic heart disease conditions is one of the largest contributors to the global burden of disease, and its impact on mortality and morbidity are typically associated with the heart failure condition. So why does it matter, or does it matter when someone is labeled an ischemic cardiomyopathy patient or a non-ischemic cardiomyopathy patient? And so first of all, I want to kind of highlight the fact that there are variations, and it's a spectrum, and not every patient with an ischemic cardiomyopathy is the same. I think that makes sense to everyone, but just to say it out loud, the individual with a long-standing history of poorly managed hypertension with a RCA lesion is a different patient than the patient with long-standing atherosclerotic cardiovascular disease, multiple MIs, and 3 vessel coronary disease. I mean, you need to realize that they're both in the spectrum of ischemic cardiomyopathy, but they need to be treated differently, and I think and that variation is important. It does matter if someone is has the cause of their cardiomyopathy is related to ischemic heart disease or not. I think this is data I pull always back as reference to one of my partners who did really wonderful work as a fellow when he was training and with access to a large registry of patients who had been biopsied in the setting of cardiomyopathy in the 1990s. And Mike Felker looked at this with his team there at Hopkins and was able to, for the first time, really clearly articulate that if you had ischemic heart disease as an etiology of your cardiomyopathy, you did much worse than patients with idiopathic or dilated cardiomyopathies in general as an outcome. And you know, I think that was an important element. Also, it's an opportunity for me to highlight the fact that there are diagnostic approaches that have to be integrated into the care of these patients when cardiomyopathy is first defined or heart failure is first defined, that allows you to be able to pull these causes apart. And that's, I think, one of the most important responsibilities of us as cardiologists treating these types of patients. This is a little bit controversial, and I could relate to the fact that, you know, it was only 15 years or so that we were debating this on big stages, where it says, well, you don't need to worry about why people have heart failure. Just treat them as heart failure. We have the meds. Just treat them as heart failure. Don't worry about whether it's related to coronary disease or this or that. And I obviously felt very strongly that that was wrong. And I as an imager at some level myself, you know, I really want to highlight the fact that it's critical to pursue kind of a diagnostic approach that is able to pull these etiologies apart. That incorporates, of course, echocardiography as a baseline to understand many elements. I think tissue characterization is a critical element with a multimodality approach. But I've always been a big believer that you cannot, for the long term, treat a patient who presents with a heart failure without understanding their coronary anatomy. We're fortunate that we have many tools now available to us. We have obviously invasive coronary angiography, but we also have coronary CT now to try to help pull those, understand the extent and severity of coronary disease. And I think the role of physiological imaging it can be quite complementary, and I think it's very, very useful in some situations. But I don't think it replaces the need to absolutely know the anatomy of the coronaries, of cardiac coronaries, in helping define treatment pathways. And that may be a discussion element and a point of controversy at a later point after I finish. Not moving forward. Here. Sorry, I'm just having a little bit of technical problems here. There it is. So let me take you on this little history lesson. So for those of you who are a little older like me, you remember the impact of the coronary artery surgery study that was done and recruited into the late 70s, early 80s. And it asked the question, what was the role of coronary artery surgery in patients who had chronic stable angina? And it was really only in the population who had a reduced LV function. And at that time, patients with EFs less than 35% were excluded because they were too high risk for coronary surgery. And in the 160 patients that were randomized in CAS with an EF between 35 and 50%, that was a population, particularly in the three vessel disease population, where there was seen an advantage of CABG versus medical therapy for the treatment of chronic stable angina. And I'm not sure if someone can help me here. We have to remember that was really in an era before what we know as medical therapy was available. There was limited aspirin use and beta blocker use. No statins were available. RAS inhibitors were not available. Obviously, the technology to mitigate sudden cardiac death or resynchronize was not available at the time. So this was kind of basically CABG versus placebo in my mind at that time. In CAS, the patients who had really lower ejection fractions, which I'll focus most of my talk on, EFs less than 35%, were excluded. Again, they were considered too high risk. And those patients were entered into a registry. And what came out of that registry, which was influencing the guidelines when I was training and really sparked my interest in this area of, it didn't make a lot of sense to me, was that if you had angina, then maybe surgery could be advantageous for you if you had reduced ejection fraction. But if you only had heart failure symptoms, they were equivalent, and you should kind of just continue with medical at the time therapy. And so this concept that angina was a driver and ischemia had to be clearly defined as a driver for benefit kind of permeated the training of generations of cardiologists for a long time, and was the driver of my kind of interest in kind of exploring that a little bit more. Was that good? Was that the right thing to do for our patients? I am now sitting in Barry Zaret's seat, but Barry and the team at Yale really challenged that dogma a few decades later, when they started with surgical colleagues recognizing that you could not only measure LV function and recovery of LV function, and they saw that there was some evidence of improvements in LV function in patients who underwent and successfully survived CABG. And so this concept of CABG reversing LV dysfunction and this concept of myocardial hibernation that could be recovered became very prevalent in our thinking and our discussions, and really drove the development of new imaging technologies and other things. But when you looked at when you looked at early case series, and this again is from John Eleftheriades and the team at that time at Yale, really we're at the forefront of looking at, of this practice of providing, even though it was not guideline directed by any means or considered standard, but providing patients who had low ejection fraction and coronary disease, cardiac, CABG. It improved New York Heart Functional Class if you survived. It could improve EF, and at the bottom there you'll see the single line, which was the survival rate of those patients. There was no comparator arm, and this was a surgical series. So this was kind of really starting to build a case that these patients could be referred to specialized centers and specialized CABG surgeons to revascularize patients, and perhaps with some improvement in their survival, but certainly improvements in function and quality of life. We took this one step further, and it's not showing here, but we did a 25-year analysis of our own data set. We have a continuous registry of cath patients that was maintained for many, many decades at Duke. And so as a fellow with great collaborators, I looked at the population of patients who had been referred, so a big referral bias, to cath, and to look at what happened to those patients if they had an ejection fraction, and this was a city angiogram of less than 35% or 40%. And what we were able to show was that while there was an early hazard if they were treated surgically, that hazard eventually was reversed, and there was a survival advantage over the 15 to 25 years of follow-up that we had available on some of these patients. And it didn't matter if they had angina or really ultra low EF, or what their age was. It was a pretty consistent finding, and that was the pilot data that we used to build a case in collaboration with the program officers and other colleagues, to pursue a large-scale analysis and evaluation in a randomized fashion of coronary surgery in patients with heart failure. And that led to this STITCH trial that Greg's referenced, that I'll spend a little bit kind of time going through it. I do want to reflect that when we proposed this, PCI was available. Stents were just kind of coming up, but and we actually proposed a 3-arm trial. We actually submitted, the application to do a large randomized trial with 3 arms, and were asked by the NHLBI and a group that they pulled together to help them review this, of luminaries in the field, some who I've continued to work with, that PCI was not proven to be safe in this population, and that it would not be appropriate, and that they would be willing to consider a trial where we applied, we actually compared CABG to the standard, which was medical therapy, and that's how we led to this 2-arm trial that became the stitch revascularization hypothesis. So what we took is, these 1,200 plus patients in over 100 sites across what ended up being over 20 countries, with an EF of less than 35%, that had coronary disease that was suitable for revascularization with CABG, and that were eligible for continuing medical therapy, which was evolving even then. And we randomized them to optimal medical therapy versus optimal medical therapy plus CABG. And you can see that this population wasn't perhaps as generalizable as we would have liked, but it's what we were doing at the time. And really, we would have loved to have more women representation. The median age was a little younger, although you'll see we have a pretty broad range of ages reflected. But most patients had prior MI that was documented, nearly 40% diabetics, pretty severe symptomatic heart failure, very, relatively low EFs, and end systolic volume indices of over 70. I mean, for those of you who don't integrate with that measure, it is proven to be one of the most powerful parameters of prognosis. It blows away EF, right? So if your volume index to BSA is big and normal is 25, this is 3 times normal size. That is one of the most important predictors of outcomes in this population. The patients had multi-vessel disease with a lot of involvement in the LAD. We randomized to CABG. CABG had to be done rapidly. We didn't exclude patients who were already in hospital, but it was more of a stable population. They couldn't have had a recent MI. And the time to CABG was 10 days. And it was, we had a surgical as well as a medical quality committees that managed and reviewed and set up standards. And obviously the internal mammary arteries were used predominantly. And so there was high use of arterial conduits. And you'll see in a moment here, the use of our medical therapies were pretty consistently excellent for the time. It's also important to recognize that this was an era before ARNIs, before SGLT2 inhibitors. And ICDs were really just, becoming standard. And it became standard in the guidelines in the midst of our recruitment. But I think we were very, pleased around the extent of medication use in both arms without any inconsistencies between the 2 arms. I mean, I kind of highlighted the stitch design a bit and the people and the individuals. And medical therapy. So let's just go to the results quickly, and I'll take you through. We'll catch up a little bit in time, but I think we'll have plenty of time for discussion because I didn't put too many slides into the deck here. So this was what we saw. Now this was 10-year results. The average follow-up was 9.8 years in this population. You can see a couple elements that I'm going to highlight. This was the intention to treat analysis. So this was all patients by what they were randomized to. Recognize that nearly 10% of patients within 1 year switched over from the randomized treatment arm to either from med to CABG or CABG who never got med. And I'll just discuss that in a moment. But if we look at just the intention to treat analysis, what you see here is an early hazard within the first 6 months to a year that favors medical therapy. And then the crossing of the curves with extending benefit out to the 10 years follow-up. This represents about a survival advantage of about 18 months on average in favor of patients who were randomized to CABG versus medical therapy alone. And this is about a 16% relative risk reduction. And if you then now look at the population as they were treated or by protocol, excluding patients who crossed over, or by looking at the patients who did cross over, but looking at them in the arm as they were treated in an as treated analysis, the relative risk reduction was about 25%. But even in the intention treat analysis, you can see an advantage in a number needed to treat about a 14, reflecting about an 8% absolute risk reduction in the time period. When you looked at cardiovascular mortality, these patients, the endpoints were evaluated by a blinded event, endpoint committee for cause of death. I think the advantage in favor of CABG is more extensive, about a 9 to 10% absolute risk reduction, about a 20% relative risk reduction. Again, just highlighting that if you look at this by treatment received, those relative and absolute risk reductions are even greater. And when you look at the endpoint of mortality, plus cardiovascular hospitalization, you see about a 28% relative risk reduction and about 11% absolute reduction. So pretty consistent findings, again, highlighting there's an early hazard, but if you can get through the early hazard, these patients have an advantage long term. And this, I think, still is the first and only assessment and evidence to support a survival advantage with revascularization in a stable population, because the overall CAS study did not show that in general. So what about other outcomes? Well, death or heart failure hospitalization, death or MI, death or stroke, revascularization, repeat revascularization procedures, it was all pretty consistent, substantial advantage in favor of that CABG arm versus medical therapy. And it's important to recognize the CABG arm wasn't CABG alone. They were receiving the same medical therapy that the medical therapy arm was receiving. When you looked at quality of life, these were dedicated core laboratories, and this was run by my colleague Dan Mark, and so it was pretty consistent finding, and using the Kansas City questionnaire, there was an advantage in favor of CABG for that group. And then when we looked at cost effectiveness, modeling it in many different ways, it was consistent with a substantial cost effectiveness in favor of the CABG arm, and at a really a reasonable willingness to pay threshold. So I think the story here was that again, upfront risk but benefit, and I think this population could provide an advantage, and that advantage was similar in many ways to what we saw with other standard care procedures. So how did then we define the population who had the most to gain? How do we try to mitigate this early hazard? And I think part of it was a priori defined as analyses that we wanted to look at. Well, could we look at anatomic and functional features? Were there testing parameters that might try to pull out the patients who would be at more advantage than others? And I think this, to me, is perhaps the best summary of the parameters that came out in the mix, which was the larger the ventricle, the worse the EF, and the worse the coronary disease, the earlier the advantage started accruing in favor of CABG. So I kind of highlight this point because I think most of us try to do everything we can to avoid risk in patients who we're putting forward with high-risk procedures. But this kind of goes against that construct, which is if you want to have the most, the biggest bang for your buck, you actually have to apply these higher risk procedures sometimes to those with the highest risk. Because in the lower risk population who might do just as well without surgery, they get the risk of surgery without potentially the long-term benefit. So again, this concept of absolute risk really should drive the procedural approaches. When we looked at age, now I preface this by saying we did not have a lot of patients in the 80s. The equipoise wasn't there for those patients at this time. I think that's shifted a fair bit now. But when we looked at age as a construct, there really was no, heterogeneity in the effect by age statistically. But when you look at this curve, you realize that, if you can get people with this kind of severity of disease early and offer them CABG, you have a longer time window to get benefit. And as and it doesn't necessarily mitigate with later age, but certainly the greatest benefit seems to be in those who are younger. Now, a lot of interest in trying to define subsets based on physiological correlates that we had been using in the treatment of these patients for a long time, over decades, and we're even in the guidelines. Angina, I mentioned the issue of angina from the CAS registry days, right? If the idea was if you had angina, maybe revascularization was valuable. If you don't have angina, just treat them like heart failure. That doesn't work, actually. When we looked at this, those patients, angina did not segregate an advantage for medical or surgical therapy. It was equally good in patients with or without angina, the effect of CABG. The issue of LV functional recovery. I mean, you have to survive a procedure to get functional recovery. So, I think when you have to remember that point, but there was no difference in terms of the EFs that were measured at 4 years and 4 months and 2 years by protocol in a blinded core lab. And I'm showing here the 4 months data, but when you look at all patients, the advantages of the medical arm and the CABG arm in terms of EF recovery was similar. So I think that the take home there is EF recovery is not driving the benefits in survival. Although perhaps less so now, this construct about viability and reversing myocardial hypertension and stunning by revascularization, and that really defines the population who has the most to gain. We didn't see that. And that was very controversial, still is very controversial. There's true believers in the world, and I was one of them. I actually went into this with the concept that this was going to be better in patients with more viable myocardium, but we never saw that. And actually, as I'll showcase here, those patients who had substantial EF recovery versus those patients who didn't have substantial EF recovery, their outcomes were similar in this population. And so it kind of goes against the concept that LV functional recovery is the goal of revascularization for these patients. It really, I think, ends up being freedom from future potentially fatal ischemic events, which I'll get to later. Looking at ischemia, imaging for ischemia, no difference. You couldn't segregate the treatment effect based on those who had more ischemia or less ischemia. And so that's kind of how we burst this evidence into the world a little bit. And it was controversial, particularly around the limited heterogeneity we saw based on parameters like ischemia testing and viability. But overall, I think reflected what our hypothesis was that revascularizing these patients led to better outcomes. Long-term, you had to wait for those outcomes and there was a risk. And could we do something to revascularize patients that had perhaps lower procedural risk? And that's the next few minutes I want to spend with is where are we with regards to that concept? I told you when we organized the program, we actually thought of adding PCI as an arm, but we felt at that time that the evidence for PCI in terms of its safety was not there to do a randomized trial. And probably it was smart because the field of percutaneous revascularization was evolving with new stent technologies and new approaches. I think I'll get to that at the end here. But where are we now? Well, there were no randomized controlled trials of PCI and chronic reduced EF heart failure prior to the REVIVE program, which I'll review with you in a few moments. Just to level set, very few patients with reduced EF were ever enrolled in CABG versus PCI RCTs. In syntax, there was less than 5% with any heart failure, and only 2% with an EF less than 30%. In freedom, only 2.6% of the patients had an LVF of 40% or less. And very few patients with ischemic cardiomyopathy were enrolled in randomized controlled trials of PCI versus MED. And in fact, Courage, as an example, excluded patients with any EFs lower than 30%. So this was a data-free space for sure. What did our registry and our experience and outcome studies show us? Well, I think the evidence from New York State Registry is one example early in this development idea was that when you took multivessel disease patients who had access to PCI versus CABG, those patients who were treated with CABG had about a 40% relative risk reduction in favor of survival versus PCI patients. Now, these are these are observational cohorts, they're biased, they may not have been given both options equally, and they were controlled as best they could, but I think this was the level of evidence that we had. When you looked at other registry data, it became clear that that PCI was becoming the standard in a way of what patients were offered for revascularization. And it was increasingly performed without really knowledge of the comparative effectiveness of it relative to medicine or CABG. And when you looked at kind of the Canadian registries, and these are quite powerful, where they look at every patient who is referred, and I think very well done studies. The suggestions were that when PCI and CABG were both options, CABG outperformed PCI in terms of its outcomes, in terms of morbidity and mortality. But yet people, our physicians, our patients were voting a little bit with their feet. They, if given an option to do PCI, that was something that they wanted to proceed with. And I think we have to recognize that and try to meet and bridge that gap, that evidence gap we have. And so meta-analyses, same story of all the compendium of smaller cohorts. CABG versus PCI had about, in this meta-analysis, about a 20% relative risk reduction. And then when you looked at pooled analysis of all these kind of larger trials, the evidence was not statistically significant, but I think the curves seem to diverge pretty consistently in favor of CABG. So why possibly could CABG be more effective than PCI for these patients? We don't have an answer, but I'm going to just throw one out here, and hopefully maybe this will be a discussion point. I think there is a recognition that completeness of revascularization matters, and there's a higher likelihood. I think you have outstanding interventionalists here who have driven programs that are world-renowned in difficult or high-risk interventions, but not everyone has that. And so, I think if you can't completely revascularize patients with a PCI, maybe that leads to at-risk myocardium. And in the heart failure reduced EF population, where there's a lot of wall stress and a lot of large volumes, small infarcts can be fatal infarcts, more so, and they can't be withstood as they are perhaps in a lower risk population. And then there's the issue of target lesion failures with PCIs that I think is well recognized. It's recent data across multiple different studies, and it's still it's not a large percentage, but if you have target lesion failure in a low EF patient, they don't have the coronary and myocardial reserve that maybe someone with an EF 50 would have, and that might be an important element. In that space, the REVIVE study was developed, and I know these investigators well. This is an important, very difficult study to do, where they basically had an unblinded randomized comparison of two different management strategies for these patients. PCI was best medical therapy or best medical therapy alone. They very much wanted to focus on a population which they thought had the most potentially to gain physiologically by targeted PCI of hibernating myocardium. And so viability was supposed was a requirement. They had to have viability in the territories that were going to be revascularized. Their EFs, was observed about 27%, and they had that viability in greater than 4 targeted segments. And CMR was used, so it was an advance in terms of our ability to more clearly define viability in segments. They enrolled 700 patients at 40 sites. And they followed them up for a little less than 4 years. It was very good follow-up. And this is what they showed. And I think this was I remember I was discussing, I remember being in the ESC, and there was like a hush in the crowd, because everyone kind of thought, gosh, this should work. It's a lower risk procedure. You don't have the early hazard of CABG. These patients are specified to have the most to gain from targeted revascularization to viable myocardium, and yet they were unable to show a benefit of PCI for all-cause mortality or heart failure hospitalization. They didn't show any evidence to suggest that in this patient population did better than medical therapy in terms of EF recovery or in terms of quality of life. And I didn't reference it, but the quality of life papers in JACC Heart Failure, the data was just presented, and it'll be published and in press soon. They tried to look at whether viability could define patients who had maybe the most benefit or not. And again, same issue that I think I showed with Stitch, that really was not really a discriminator. And whether or not your EF recovered didn't also define a population who gained the most from the revascularization with PCI. What they did show is that because of the advantages with guideline-directed medical therapy, event rates have certainly been declining over time, and this group of patients who were enrolled in the revived PCI were had less risk than the patients that we had enrolled in Stitch. So there's been a change in the medical treatment over time. So kind of just to summarize, a lot of data really quickly in a kind of 20 plus years of kind of exploration in this field with these types of patients. What do the guidelines tell us? Well, these are this is kind of a compendium of the ESC and the AHA, ACC guidelines from both surgical committees as well as medical and interventional committees. And there's pretty consistent basis that GDMT for heart failure with EF is the standard. It improves clinical outcomes. It is associated with reductions in cost. It improves quality of life. And, sometimes it improves EF, although I have become, I'm not a big believer that EF changes should drive decisions on treatment at this stage based on the data that's available. I think from the Stitch trial, only, that one trial, but I think replicated in different registries now, CABG plus GDMT is advantageous. It improves clinical outcomes. It's very, very solid absolute risk reduction. It's cost effective. It has improved quality of life, at least after 3 to 5 years. And the EF didn't really change too much with revascularization. And PCI, I think, really based on revived and the data from the registries, the jury's still out whether this can be done and have the same effect and advantages as revascularization with CABG as a supplement to GDMT. So what's coming down the pike? And I think, the field, the percutaneous approaches are still evolving. And I think we have also supportive devices. There was really great data shown at ACC on Impella. But it still, I think, needs to be studied. And there are groups that are looking at supported PCI in these types of patients and whether that support is associated with a better outcome if a patient and their team is going to pursue PCI as a revascularization strategy. This is not compared to either medical therapy or CABG. This is just whether PCI with or without support is better. And then we have developed methodologies in a kind of a new federated type model to bring multiple collaborators across the globe together. And we'll be doing this program, which is kind of Stitch 3, so to speak, which is currently funded and enrolling patients in Sweden and Denmark, in the UK and Canada. And we're in the midst of working through our funding. And the federated model is, and Greg and I talked about this a little bit, is before, the old days, we got this big grant and we paid for everybody's enrollment at all our countries. So, I don't think we're in a different world now. And so each country is funding their own enrollment. We have harmonized data sets for the main mortality evaluations. And then each kind of group of investigators are diving into kind of physiological questions as part of their focus within their country. So we'll be able to answer a mortality question by enrolling 400 or 500 patients in each country. And hopefully the US will come online if we can get funding support for that. And so that's coming up. And I think that will be the way to extend our knowledge about how PCI can, how it can complement the revascularization strategy for these patients. So I've taken you through a quick tour, hopefully left a lot of time for questions. But this is where I stand with regards to this field. And I, arguably spent 25 years of my life kind of trying to move this forward a little bit. Is first and foremost, I can't highlight this enough. I think we skipped through some of those slides when I was having problems, but the evidence suggests that when patients are hospitalized for heart failure, we do a terrible job evaluating for the extent of coronary disease. From multiple data sets, get with the guidelines, as well as other payer data sets. On average, within a 6-month period from a new diagnosis of heart failure, only 30% of the patients have any evaluation for coronary disease. I'm not talking about coronary anatomy with cath or CT. I'm talking about any ischemic evaluation, any evaluation. So, that's not happening, I hope not here, probably doesn't happen a lot in Yale, but across the country, many patients who present with a reduced ejection fraction do not ever get evaluated for the extent and severity of coronary disease, and therefore cannot ever be treated effectively for atherosclerotic coronary disease potentially, and offer the opportunity to have an advantage with a revascularization strategy. CABG improves survival with less mortality and morbidity compared to med, but it has to be recognized that GDMT is advanced. So we didn't have ARNIs in the era. We didn't have SGLT2 inhibitors. So I think are, we can't stop with the past. We have to continuously evaluate and test strategies of how we treat our patients into the future. And so I think, obviously in Stitch 3, we'll be incorporating those kind of medications in our analyses. Based on my, study of this, and even though it was against the hypothesis that I had driven, it really brought me here, viability, anginal status, and ischemia are, I think, important physiological constructs that can be helpful in an individual patient's decision-making, but on a population basis, I don't think should define the candidacy for patients for revascularization. They just don't show, they're not seen to be particularly effective. There's no heterogeneity in effect. Survival was improved regardless of anginal status, viability status, or ischemia status in Stitch-like patients in our trial. What really matters is trying to identify those patients who have the most to gain, and that looks to be those patients who have the most severe disease based on the extent of their coronary disease, their size of their ventricles, and with lower EFs. And that's kind of how I've integrated this information into my practice. We didn't spend any time on this, but I would just highlight the revascularization mechanisms of CABG are multifactorial. It probably is about coronary and myocardial reserve. And in that population, maybe distinct from the population who has an EF of 50%, small ischemic events, infarcts, can be quite problematic, and they don't have the coronary and myocardial reserve to withstand that. And so I think completeness of revascularization in that population might be really something we have to drive towards, because they're unable to have that reserve that maybe we see in other patients. I mentioned PCI is less well studied. Revive suggests a limited role for now, but I think we're still continuing to pursue it. And patients are kind of voting with their feet. They want that option if it can be equally advantageous. And I think we have to continue to evaluate that. And I didn't spend any time talking about the population that's very large of patients with heart failure who have preserved EF, but believe it or not, that population is even less well studied, and we have a lot to learn in that goal. So with that, really thank you. Sorry about the technical difficulties, but I think we made up some time. So
yeah, thank you so much. That was great. And we do have time for questions. And so I'm actually going to bring
Thank you very much for the great talk. And also thank you for taking on these types of trials where there isn't a clear-cut industry sponsor, because I know what a bear it is to try and convince the NHLBI to make the type of investment. So kudos for that. Stitch was a real pivotal trial because it sort of shot down a lot of the sort of ideas I had about ischemic cardiomyopathy and why I was sending people for revascularization. And I know you didn't get into it too much, but whenever I ask somebody, well, why did cabbage work better? They always tell me more complete revascularization. But what is the action? And then you mentioned it again, that it has to do with these microinfarcts. Is there actually data that the benefits in Stitch were proportional to the number of bypasses? Were there follow-up scans done to show there was, that the benefits were proportional to residual ischemia or viability? Like what? I feel I like the idea because it allows me to save some face to these hypotheses I've had for, whatever number of years, but I haven't actually seen the data.
So, and it's a great question, and it's a limitation. I mean, it's one of these things where, you build these Christmas trees and you realize they get very heavy with a lot of things that hang them down and can topple them. So we had, 5 core laboratories funded to do imaging, blinded imaging and stuff. And some of that has been pulled apart. The data, we had a CMR core lab, and frankly, that's been an area where we still have some analyses to do to try to pull that out. But I don't think we'll ever get to answer the question because we didn't have follow-up CMR. We don't see large, among survivors, we don't see large differences in EF and ESVI, but that's among survivors, of course. What is the best evidence that I think we have is that we did look at, we adjudicated causes of death. So we, people who are blinded potentially and were not part of the executive committee, looked at every patient who died and described an etiology for their, and clearly what we saw was the population that MI, fatal MI, was kind of the driver of that advantage in mortality. And so we've kind of, that's not as good as we need, but that's kind of a driver that we're thinking that these patients, it wasn't heart failure, it wasn't pump, I actually, my bias when I went into this thing, it was like, well, we're going to reduce pump failure deaths. That wasn't the case. In fact, it was fatal MI and sudden death, which were the drivers of the advantage. And that's kind of the best I have to address the hypothesis.
I think we might have time for one more question here.
That was a fabulous talk. Thanks so much, Eric. It strikes me that this is very continuous with a lot of the other things that we're now thinking about, quote unquote, viability and imaging. Same thing with aortic stenosis and low-dose tubulotomy stress. We don't really do that anymore because it doesn't help us find the patients who shouldn't get it. And it sounds like Stitch and other trials are changing our paradigm from let's find a way to save money by not doing interventions on people who are not going to benefit, but rather people are going to benefit, but we will be able to identify a high-risk subgroup. And maybe rather than saying, no, you can't have this intervention or it won't do you any good, we say, you know what, you usually see palliative care before you have that intervention, but we know that you're going to benefit it, maybe just not to the same extent as someone who actually has viability.
Yeah. I still see myself, I harbor a sense, I used to run the cardiovascular imaging laboratories at Duke for many years. And Bob Bono and I walked around with targets in our back, when we published the viability stuff, right? I mean, it was like, this is crazy, like, this is wrong. It can't possibly be that viability doesn't discriminate, right? I think your point is extremely, valid. I do think this has helped us change the construct a little bit of like what we're trying to do with this imaging. When you have a surgeon or interventionalist that has the technical competencies and has the ability and wants to do the procedure, they don't ask for viability studies, right? So first and foremost, when I looked at our own data, the patients who were most likely to be receiving ischemia and viability testing who had, the Duke data set, were patients who had who were lower socioeconomic status. This is the only time I've ever seen that race actually led to more procedures than not. I mean, so Black patients were more likely to get SPECT and PET and SPECT imaging than white patients who had low EF. And that was because, I mean, my interpretation was like, you were doing this to avoid something, right? And so I think that's kind of how I've interpreted this. Is I was a believer too. I wanted to believe, but it is. I sense my take home around this is that it can be still very helpful to position the discussion with patients, but we shouldn't be doing these procedures with some sense that by improving their EF by 5 points, they're gonna live longer. That's not, I think, the mode of how this works, in my opinion.
So I'm going to give you our last question, which is actually from Dr. Danik, who's remote, and I'm going to transform her question into a what would you do kind of personal question. So when your patients get turned down by the surgeons, would you send them with a low EF for PCI?
Well, my first question is, what can they do? Right? I mean, I think, it's at this point, it's a technical issue, and I think we have to individualize care. So if the patients, can be approached, it's a conversation that we had. You have to individualize care, but I do send them. I think, I think the data in a population basis is not there to suggest that PCI should be the standard. It is what we're doing more of, frankly, and that worries me a little bit because we need to not get too far in front of the evidence. But if a patient is symptomatically doing worse with heart failure and has substantial coronary disease, and I have confidence in the competency, technical prowess of the team, and they can revascularize multiple segments, I pursue it. I don't know if that's what you guys expected me to say, but I think you have to individualize care.
I think it's a good answer. We'll end it there. Thank you so much. And